ahead and get started. Thanks for attending my CE presentation. If you don't know who I am, my name's Kendall. I'm one of the PGY1 pharmacy residents here at Erlanger. And today I'm going to be talking about Sglt2 inhibitors, and the title of my presentation is Go with the Flozin, a comprehensive review of Sglt2 inhibitors. So by the conclusion of this presentation, audience members should be able to identify adverse effects, contraindications, and renal parameters of Sglt2 inhibitors, differentiate the proposed mechanisms of action of Sglt2 inhibitors in different disease states, compare and contrast primary literature related to Sglt2 inhibitors, and select the appropriate use of Sglt2 inhibitors based on guideline recommendations. So we're going to jump right in with a couple of test your knowledge questions. Feel free to shout out your answer after I go through the options. This first one asks, which of the following is not an adverse effect associated with Sglt2 inhibitors? A, urinary tract infections, B, euglycemic DKA, C, volume depletion, or D, loss of appetite? Any ideas, guesses? D. That is correct. So the first three are all associated with Sglt2 inhibitors, while D, loss of appetite, is more so related to GLP-1 receptor antagonist or agonist. And the second question, which of the following is the correct mechanism of action of Sglt2 inhibitors in diabetes? A, they reduce gluconeogenesis and decrease insulin resistance. B, they increase the excretion of glucose through the urine. C, they inhibit GLP-1 degradation, or D, they increase insulin secretion from the pancreatic beta cells. B, correct. So the other three are related to other diabetes medications, but Sglt2 inhibitors specifically in diabetes work by increasing the excretion of glucose through the urine, and we'll talk a little bit more about this later. So just to jump in with the specific Sglt2 inhibitors we'll be talking about today. There are 4 approved in the United States. However, there are 3 main ones that we'll focus on because that's what the literature focuses on. So canagliflozin is Invokana. It was approved in 2013, and it comes in both 100 and 300 milligram tablets. Dapagliflozin is Farxiga, approved in 2014, comes in 5 and 10 milligrams. Empagliflozin is Jardiance, again approved in 2014. It comes in both 10 and 25 milligrams. And then ortugliflozin or Sglt2 is the most recent one, approved in 2017. There's not too much literature, but it is approved in the US, so there's a possibility you could see it. And that one comes in both 5 and 15 milligram tablets. So kind of jumping into the safety profile of these medications, first focusing on the adverse events. So they are not benign drugs. They definitely have some adverse events that are possible. And these include genital mycotic infections, ketoacidosis, euglycemic DKA, hypotension, volume depletion, hypoglycemia, Fournier's gangrene, and then bone fracture or amputation, which is more so associated with canagliflozin. As you may know, back in 2017, the FDA did release a black box warning for canagliflozin. Based on the literature at that time, the black box warning was due to increase of leg and foot amputations. However, this black box warning has more recently been removed. So in 2020, based on literature that came out later, the FDA removed the black box warning, saying that safety information from recent trials demonstrated that the risk of amputation with canagliflozin is lower than previously described. So just an adverse effect, not necessarily a black box warning anymore. And then we'll jump over to contraindications for the use of Sglt2 inhibitors. The first being hypersensitivity to any component of the medication. And then patients who are on dialysis, have end-stage renal disease, or severe renal impairment. And on that note, we'll talk a little bit more about the renal parameters of these medications. I will just preface that these are the package insert renal parameters from the FDA. However, due to more recent literature and how they were studied, some of these are not used quite as strict, just from more recent information that's come out. So for canagliflozin, its maximum dose is 100 milligrams if the eGFR is less than 60. And if eGFR is less than 30, they're not recommended. For dapagliflozin, there's no dose adjustments at greater than 45. At an eGFR less than 45, they're not recommended, and less than 30, they're contraindicated. And then for empagliflozin, it should not be initiated or continued with an eGFR less than 45. All right, now I'm going to break it down by disease state and go through the literature that's come out. So in the past 6 years, there's kind of been an explosion of literature regarding SGLT2 inhibitors in different disease states. So we're really going to break that down. First, starting with type 2 diabetes. So looking at that mechanism that we talked about a little bit earlier. So SGLT2 inhibitors work right here on the proximal tubule in the kidneys, and they work in diabetes by decreasing the renal tubular glucose reabsorption, which increases glucose excretion into the urine. So this mechanism is dependent on the blood glucose, but independent of patients' insulin levels. So just before we jump into diabetes literature, as a reminder, in 2008, the FDA issued some guidance that all new diabetes medications in their studies, they should rule out cardiovascular risk by including these MACE outcomes, or major adverse cardiac events. And this is due to the high prevalence of cardiovascular disease in patients with diabetes and some adverse cardiovascular risks with the TZD medications at the time. So these MACE outcomes can include cardiovascular death, non-fatal MI, stroke, and sometimes unstable angina, or sometimes it's just the first three. So we'll get started. This is the timeline of the literature that's come out since 2015 for every disease state. And we're first going to jump in starting in 2015 with the EMPA-REG outcome trial. This trial was titled Empagliflozin, Cardiovascular Outcomes in Mortality in Type 2 Diabetes, published in 2015 in the New England Journal of Medicine. So the population studied in this trial were all patients with type 2 diabetes plus cardiovascular disease. Of note, the population at baseline had a pretty low percentage of heart failure patients, and the average EGFR was about 74 milliliters per minute at baseline. This study looked at empagliflozin 10 milligrams, 25 milligrams versus placebo, and its endpoints, like mentioned earlier, were those major adverse cardiovascular events. Those were the primary endpoints. Some secondary endpoints included the composite of MACE plus hospitalizations for unstable angina, and it also wanted to look at the adverse events with empagliflozin. As a result, the study found that empagliflozin has significantly lower risk of major adverse cardiac events with the hazard ratio of 0.86, and this was primarily driven by the reduction in cardiovascular death. Other subsequent findings were that there was significantly lower risk of death from any cause and a lower risk of hospitalization for heart failure. So as I mentioned, the baseline population of heart failure patients was only about 10%. So this was really focusing on decreased first hospitalizations for heart failure. Other subsequent findings were a mild decrease in A1C of about 0.56 for 10 milligrams and 0.6 for 25 milligrams, as well as moderate weight reduction, waist circumference reduction, uric acid level, and decreased blood pressure as well. The study also found that genital infections were the most common adverse effect, more common with empagliflozin than placebo. So moving right along to 2016 with the EMPA kidney trial. This, again, was in New England Journal of Medicine in 2016, entitled Empagliflozin and Progression of Kidney Disease in Type 2 Diabetes. So this study actually reflected the EMPA-REG trial almost identically. Similar population, however, these patients also had an eGFR of less than 60 milliliters per minute. And as far as composite of microvascular events. So the endpoints really focused in on those microvascular endpoints, specifically the incident or worsening of nephropathy, doubling of the serum creatinine, plus an eGFR less than or equal to 45 milliliters per minute, the initiation of renal replacement therapy or death from renal causes. And these endpoints had a relative risk reduction of 39, 38, 44, and 55% respectively. So as a result, this trial concluded that empagliflozin 10 or 25 milligrams resulted in significantly lower risk of microvascular outcome events as compared to placebo. And this was primarily driven by that lower risk of progression of kidney disease. Subsequently, the study also found that this patient population at baseline already had well-managed blood pressure, and 80% were already taking an ACE inhibitor and ARB. So it's something to keep in mind. The results of this trial really can't be extrapolated to those who are not on an ACE or an ARB at baseline, which is kind of our mainstay medication for renal protection. And they found that empagliflozin did not prevent albuminuria like we know ACEs and ARBs can do. So these results are also not generalizable to patients at lower cardiovascular risk, just because, again, the population at baseline, they all had cardiovascular disease. All right, moving on to our CANVAS trials in 2017. In the New England Journal of Medicine, canagliflozin in cardiovascular and renal events in type 2 diabetes was published. This is actually 2 trials combined into one, so the CANVAS and the CANVAS renal trial, and they were combined for a greater power. So the population at baseline all had type 2 diabetes, and a little bit different from the previous trials, these patients either had ASCVD or had risk factors for cardiovascular disease. Of note, only about 14% of these patients had heart failure at baseline, and the mean eGFR was 76.5 at baseline as well. So the CANVAS trial was looking at canagliflozin 100 milligrams versus canagliflozin 300 milligrams versus placebo, whereas in the CANVAS renal trial, patients were started on the 100 milligrams and increased to 300 milligrams, which was compared to placebo. The endpoints in these trials was major adverse cardiovascular events, MACE outcomes, as well as progression of albuminuria, death from cardiovascular causes, and hospitalization from heart failure. So they kind of pulled from those results that previous studies had found and looked more closely into that albuminuria and especially hospitalizations for heart failure as well. And then thirdly, they looked at adverse events, really specifying the bone fracture, the risk of bone fracture with canagliflozin. As a result, the CANVAS and CANVAS renal trials found that canagliflozin resulted in a significantly lower rate of MACE outcomes with a hazard ratio of 0.86, so pretty consistent with previous literature. Other findings included decreased risk of hospitalizations for heart failure, again, consistent with the previous literature, decreased risk of progression of albuminuria and loss of kidney function. So this was a little bit different than the IMPA kidney trial. They found that Sglt2 inhibitors may have a protective renal effect in patients with type 2 diabetes. And then finally, they did see that increased rate of amputation with canagliflozin. This was in the CANVAS trial only. So this subsequently led to that 2017 black box warning from the FDA. All right. And then finally, one of our last diabetes trials is the DECLARE-TIMI trial. This was in 2019, entitled Dapagliflozin and Cardiovascular Outcomes in Type 2 Diabetes, again published in the New England Journal of Medicine. This trial, actually, their study design changed a little bit of the way through based on the previous trials. They wanted to make their endpoints reflect it. So just something to keep in mind, all these trials happened so close together, they kind of started pulling from others once they saw the results. So this trial looked at all patients with type 2 diabetes, and these patients either had ASCVD or risk factors for cardiovascular disease. At baseline, there was a relatively low percentage of heart failure patients, and the eGFR at baseline was about 85 milliliters per minute for the average patient. This DECLARE-TIMI trial looked at dapagliflozin 10 milligrams versus placebo. Again, those endpoints are similar to previous trials with MACE, cardiovascular death, or hospitalizations for heart failure. Some secondary endpoints include composite renal outcomes. The results of this trial found that dapagliflozin is non-inferior to placebo in regards to MACE. So this was actually the first trial to find non-inferiority rather than superiority as in regards to MACE outcomes. It also found that dapagliflozin was superior in regards to cardiovascular death and hospitalizations for heart failure. Some subsequent findings from this trial were lower rates of progression of renal disease, so pretty consistent with previous literature. And they hypothesized that patients without established ASCVD can also get those cardiovascular benefits from Sglt2 inhibitors. And the trial did find a higher incidence of DKA and genital infections with dapagliflozin. So now that we've looked at the diabetes trials with Sglt2 inhibitors, I'm kind of going to focus in on how the most recent ADA guidelines have reflected these results. So in 2020, the American Diabetes Association published this guideline algorithm. And so first-line therapy remains to be metformin plus lifestyle modifications. Nothing has really changed there. However, the guidelines then go on to say that you should look at indicators of high risk or established ASCVD, CKD, or heart failure in your patients, and potentially consider a medication that has benefit in one of those disease states, regardless of what their A1C is at the time or what their A1C target is. So in these patients, if ASCVD predominates, or high risk for ASCVD, they would benefit either from a GLP-1 receptor agonist that has cardiovascular benefit or an Sglt2 inhibitor that has cardiovascular benefit. So remember, those are empagliflozin and canagliflozin because dapagliflozin only showed non-inferiority with their MACE outcomes. And then if we jump over here, if the patient has heart failure or CKD that predominates, then they would benefit, and this is specifically heart failure with reduced ejection fraction, and specifically CKD with an eGFR between 30 and 60, or a urine albumin to creatinine ratio greater than 30. They would benefit from an SGLT2 inhibitor with benefits in those disease states, which would be empagliflozin, canagliflozin, or dapagliflozin. So additional considerations when adding an SGLT2 inhibitor to a diabetic patient, there are some pros and cons that go past just the literature that we talked about. Some additional benefits that you might get would be the mild or moderate weight loss, some blood pressure lowering effects as well. These medications do have minimal hypoglycemia risk as compared to like your insulin, your sulfonylureas, and they are an oral tablet, so not an injection like we think about with insulin or GLP-1. Some cons, so some things that really should also be kept in mind are the cost. These are all brand name medications still, and so cost can be a significant factor for patients receiving this medication. Additionally, the renal function, so these are based on renal parameters and not all patients would qualify. And then adverse effects. So again, these medications aren't benign and the adverse effects are very possible. So now we're going to jump into chronic kidney disease and the literature that's come out about this disease state. So CKD actually has some different theorized mechanisms of benefit, and it is theorized that they decrease sodium reabsorption in the proximal tubules, increase sodium delivery to the macula densa, and this leads to afferent vasomodulation and decreased hyperfiltration. So as we look back at the timeline in 2019, the CREDENCE trial also came out. This was the canagliflozin and renal outcomes in type 2 diabetes trial and nephropathy trial in New England Journal of Medicine. So the CREDENCE trial, the population that they included, all 100% of patients had type 2 diabetes, like previous literature, and they included patients with CKD and wanted at least 60% of these patients to have an eGFR between 30 and 60. And at baseline, all these patients were on an ACE or an ARB. Of note, about 15% of these patients had heart failure at baseline, and the mean eGFR at baseline was 56 milliliters per minute, which is a bit lower than the previous trials. The intervention was canagliflozin 100 milligram versus placebo, and the primary endpoint was composite of end-stage kidney disease, dialysis, or as defined as dialysis, kidney transplant, and eGFR less than 15 milliliters per minute, doubling of serum creatinine, and renal or cardiovascular death. Other endpoints include cardiovascular death, hospitalizations for heart failure, or MACE. So they kind of pulled in those endpoints that most of the other trials have looked at. And they also looked at adverse events, again, specifically wanting to look more into this amputation risk. As a result, the CREDENCE trial found that canagliflozin had significantly lower rates of progression to end-stage kidney disease with a hazard ratio of 0.7. They also found lower secondary cardiovascular endpoints, no significant difference in the risk of lower limb amputation or fracture between canagliflozin or placebo. So this was the point at which the FDA removed the black box warning. And they hypothesized that canagliflozin may be an effective treatment option for renal and cardiovascular protection in patients with type 2 diabetes and CKD who are already on an ACE or an ARB at baseline. And they also hypothesized that the benefit of SGLT2 inhibitors is likely independent of glucose levels, which was kind of a big deal because at this point, all of these patients have had type 2 diabetes. And this really led into the idea of maybe using this medication in non-diabetic patients. So with that, we'll jump into the DAPA CKD trial. And it was in 2020. So this was the dapagliflozin in patients with chronic kidney disease in the New England Journal of Medicine. And this was one of the first trials to look at patients without type 2 diabetes. So at baseline, the population had an EGFR between 25 and 75 milliliters per minute. So they kind of went under those renal parameters that we talked about earlier. Patients also had a urine albumin creatinine ratio of 200 to 5,000 and were on an ACE or an ARB at baseline. So notice that only about 67% of these patients had type 2 diabetes at baseline. Only about 11% had heart failure, and the average EGFR was about 43 milliliters per minute. This trial looked at dapagliflozin 10 milligrams versus placebo, looking specifically for that first occurrence of either an EGFR decline of 50%, the onset of end-stage kidney disease, kidney transplant, or death from renal or cardiovascular causes. Some secondary endpoints include composite renal outcomes, hospitalization for heart failure, cardiovascular death, and death from any causes. So the DAPA CKD trial concluded that there's a significantly lower rate of primary renal outcomes in patients both with diabetes and without, with hazard ratios of 0.64 and 0.5 respectively. Some other subsequent findings are that there were lower rates of hospitalization for heart failure and cardiovascular death, which is consistent with previous literature. And this study also supported the use of SGLT2 inhibitors in addition to ACE or ARB therapy for management of CKD without type 2 diabetes. Another finding that they found, and that has been proven in other studies as well, is that when patients are started on an SGLT2 inhibitor, there's a kind of an initial dip in the EGFR followed by stabilization of renal function. And so this has actually been looked into a little bit more, and they found that while there's an initial dip, it does stabilize, whereas the patients who received placebo, that decline just steadily kept going. And they also found that if you were to take the SGLT2 inhibitor away, the EGFR does return to baseline. All right, so now looking into how these CKD trials were incorporated into guideline therapy. In 2020, the KDIGO guidelines recommended treating patients with type 2 diabetes, CKD, and an EGFR of at least 30 with an SGLT2 inhibitor. So from this graph, you can see first they recommend lifestyle therapy, and then next they recommend metformin if renal parameters allow, plus an SGLT2 inhibitor, again, if their EGFR qualifies and they're not on dialysis. And so these two medications are recommended before any other glucose lowering therapy in these patients. Some additional considerations from KDIGO is that it may be necessary to stop or reduce the dose of an antihyperglycemic drug other than metformin to facilitate the addition of an SGLT2 inhibitor. You may consider decreasing a thiazide or loop diuretic dose before initiating the SGLT2 inhibitor, just because of those diuretic effects of the mechanism of SGLT2 inhibitors. And finally, once initiating the SGLT2 inhibitor, it is reasonable to continue even if the EGFR does decline below that 30 milliliters per minute, as long as the patient continues to tolerate it. So those were the KDIGO guidelines of patients with diabetes. There have been no update of recommendations for CKD patients without diabetes. All right, so time for another test your knowledge question. Which of the following are proven benefits of treatment with SGLT2 inhibitors in diabetes? A, A1C lowering. B, modest weight reduction. C, reduced progression of renal disease. D, reduced adverse cardiovascular events. Or E, all of the above. Correct. So all four of these are proven benefits that we've talked about previously of SGLT2 inhibitors, specifically in diabetes. All right, and we're going to jump into our last disease state that I'm going to talk about, and this is heart failure. So again, there are some theorized cardiovascular benefits of SGLT2 inhibitors in heart failure. Some of these include their diuretic effects, their antihypertensive effects, that they have reverse cardiac modeling, that they reduce oxidative stress, and they improve cardiac contraction. Again, the mechanisms of these aren't well known, but these are some theories. So when we think about heart failure, we break it down into 3 classifications, first of which is heart failure with reduced ejection fraction, defined as an ejection fraction of less than or equal to 40%. As we know, that guideline-directed medical therapy, or GDMT, is the standard of care for patients with heart failure with reduced ejection fraction. So things such as ACE inhibitors, ARBs, ARNIs, and then our heart failure beta blockers as well. And when we think about heart failure literature, the standard endpoints are decreased mortality and prevention of hospitalization. So just things to keep in mind as these SGLT2 inhibitors literature regarding heart failure come out. So if we backtrack to 2019, this is when the DAPA-HF trial came out. It was entitled Dapagliflozin in Patients with Heart Failure and Reduced Ejection Fraction, again, in the New England Journal of Medicine. So this trial looked at patients with heart failure with reduced ejection fraction, so an EF less than 40, plus patients in the New York Heart Association functional class 2, 3, or 4, plus these patients should already be on GDMT at baseline. So of note, the average ejection fraction of these patients was about 31%. Only about 42% of the patients had type 2 diabetes at baseline, so this trial did look at both with or without diabetes. And the average eGFR at baseline was 66. So DAPA-HF looked at dapagliflozin 10 milligrams versus placebo, looking specifically at cardiovascular death or worsening heart failure, which is consistent with heart failure literature. And it also looked at total number of hospitalizations, change in symptom score, and composite of worsening renal function. As a result, DAPA-HF found that dapagliflozin resulted in significantly lower rates of hospitalization or death from heart failure. So the trial found that this benefit was equal in both diabetic and non-diabetic patients. However, it did find potentially greater benefit in patients in New York Heart Association functional class 2, so those with less severe symptoms. And they hypothesized that SGLT2 inhibitor benefit extends beyond glucose lowering and potentially extends the therapeutic role of these medications beyond patients with type 2 diabetes. And they also say that they also included very few elderly patients, African-American patients, or patients who were on Entresto at baseline. So just things to keep in mind that these patients, the results of this study really can't be generalized to these patients. So next, in 2020, the Emperor-Reduced trial came out following the DAPA-HF trial. And this was the cardiovascular and renal outcomes with empagliflozin in heart failure, published in the New England Journal of Medicine. So this trial was pretty similar to DAPA-HF. It looked at patients with an ejection fraction less than 40%, New York Heart Association class 2 through 4, plus GDMT at baseline. The average ejection fraction at baseline was 27%, and about half of the patients had type 2 diabetes at baseline. And the average eGFR was 62 milliliters per minute. The intervention in this trial was empagliflozin 10 milligrams versus placebo. And the endpoints, again, similar to the last, were cardiovascular death or hospitalization for heart failure. It also looked at the total number of hospitalizations for heart failure and the rate of decline of eGFR. So Emperor-Reduced concluded that empagliflozin results in significantly lower risk of cardiovascular death or hospitalizations for heart failure with reduced ejection fraction as compared with placebo, with a hazard ratio of 0.77. So these findings were consistent among those with and without type 2 diabetes. They found a slower decline in eGFR with empagliflozin. And they actually found that there's a potentially greater benefit in patients who were already being treated with an ARNI. So they did make an effort to enroll more patients being treated with Entresto at baseline and found that there's potentially greater benefit in those patients. This study concluded that the results, or that the benefits could extend to those with more advanced heart failure with reduced ejection fraction. And they found more frequent genital tract infections with empagliflozin, which is expected with this class of medication. So the guidelines have been updated to reflect these two trials. In 2021, the American College of Cardiology, or ACC, released an expert consensus with this treatment algorithm. And so they recommend that SGLT2 inhibitors be added to patients with heart failure with reduced ejection fraction with or without type 2 diabetes. Patients should be in New York Heart Association functional classes 2, 3, or 4. They must meet the renal criteria, and the SGLT2 inhibitors should be added in addition to their GDMT. So of note, the consensus always also says that achieving target or maximally tolerated doses of other medications is not necessary before adding an SGLT2 inhibitor. So those target doses of beta blockers or ACE/ARB do not have to be met first. And they say that loop diuretics or glucose-lowering medications may need to be dose-adjusted prior to starting the SGLT2 inhibitor because of those diuretic and glucose-lowering effects of the medications. And also of note, dapagliflozin and empagliflozin are the two they recommend, just because those are the trials that looked at heart failure. And the starting and target doses of those are all 10 milligrams in heart failure. All right, so moving past heart failure with reduced ejection fraction, next would be heart failure with mid-range ejection fraction, as defined as an ejection fraction between 41 and 49. This classification of heart failure is not studied very often. There's a lack of literature in this specific population. However, these patients are commonly treated with GDMT as though they were heart failure with reduced ejection fraction, just because they're kind of on that borderline cusp of being reduced. So we'll jump into heart failure with preserved ejection fraction, which is defined as an ejection fraction of 50 or greater. This disease state is largely a diagnosis of exclusion, so it's not as clearly diagnosed as heart failure with reduced ejection fraction. However, the incidence and mortality of patients with heart failure with preserved ejection fraction are actually nearly equal to those with reduced. So it's still a very large patient population. We just really don't have that much proven benefit with any specific medication therapy. So just looking at what we do know about this disease state, in 2013, we have the ACC-AHA heart failure guidelines. They recommend treating systolic and diastolic blood pressure according to practice guidelines. Diuretics could be used if symptom relief is needed due to volume overload. And they recommend maybe using beta blockers, ACEs, ARBs, if needed for hypertension, to treat hypertension, but they shouldn't necessarily be added like GDMT is added to heart failure with reduced ejection fraction. And they say ARBs might be considered to decrease hospitalization in heart failure with preserved ejection fraction. So based on the CHARM preserved trial, there was moderate effects or moderate benefits with ARBs in decreasing hospitalizations for heart failure with preserved ejection fraction, but it's really the only main recommendation we have. So just as a review, the current treatment for this disease state is aimed at just treating the symptoms, treating the comorbidities, and treating the risk factors that could lead to worsening cardiovascular disease. But there's really lacking treatment that decreases hospitalizations and decreases mortality and morbidity. So that was until 2021. August of this year, the Emperor Preserved trial was released, and it is entitled Empagliflozin in Heart Failure with Preserved Ejection Fraction, again, in the New England Journal of Medicine. So this trial looked at patients with heart failure with preserved ejection fraction, as defined as an ejection fraction greater than 40% in this trial. Patients also should be in the New York Heart Association class 2, 3, or 4, and they should be on their usual therapy as well for whatever comorbidities or symptoms they have. Of note, about 50% of these patients had type 2 diabetes. The average ejection fraction of patients was about 54%, and the average eGFR was 61 milliliters per minute. So Emperor Preserved looked at empagliflozin 10 milligrams versus placebo, specifically looking at cardiovascular death or hospitalizations for heart failure. So again, consistent with those endpoints of previous heart failure trials. They also wanted to look at total number of hospitalizations for heart failure and rate of decline of eGFR. So this is pretty identical with the Emperor Reduced, just a little bit different patient population. As a result, the Emperor Preserved trial found that empagliflozin had significantly lower incidence of hospitalizations for heart failure with preserved ejection fraction than placebo, with the heart hazard ratio of 0.71 and less reduction in cardiovascular death, so hazard ratio of 0.91. So these are really driven by that reduction in hospitalizations. However, this trial did see high rates of serious adverse events and discontinuation of the study drug. These were equally distributed among those receiving placebo and the empagliflozin. However, this fact could affect how the results turned out. And the findings were also consistent with those with or without type 2 diabetes. So I wanted to look a little bit closer into the ejection fractions of patients that were included, just to see if was there greater benefit with those with the lower ejection fraction, mostly because they were closer to reduced heart failure with reduced ejection fraction. However, the benefit was pretty consistent. So those with an ejection fraction less than 50% had a hazard ratio of 0.71. Between 50 and 60%, the hazard ratio was 0.8, and then greater than 60%, it was about 0.87. So in contrast to previous trials for heart failure with preserved ejection fraction, these results favored empagliflozin for the primary outcome in each of the ejection fraction subgroups. So there was a benefit regardless of how high that ejection fraction was. So there's no updated guidelines when it comes to heart failure with preserved ejection fraction. These just came out in August of this year. However, that was the first trial really to show mortality, morbidity benefit in heart failure with preserved ejection fraction. So exciting things. This is our last test your knowledge question, and it is SGLT2 inhibitors are included in guideline-directed therapy for each of the following disease states except A, type 2 diabetes alone, B, type 2 diabetes plus CKD, C, ASCVD alone, or D, heart failure with reduced ejection fraction alone. Any guesses? Correct, C. So remember the trials that looked at ASCVD, all of the patients also had type 2 diabetes. All right, so now moving a little closer to home for the Erlanger formulary, we have dapagliflozin 5 milligrams and 10 milligram tablets on formulary. So if you were to order empagliflozin or canagliflozin, these nice charts would come up kind of directing you to the dose that you should pick. However, as of a note, these medications can be safely held while a patient is inpatient if the provider doesn't want to switch from their home medication to dapagliflozin. And for patients where the conversion is not suitable, you can select non-formulary and do the home supply option as well. Additionally, each of these 3 SGLT2 inhibitors are available for less than $20 per month with the Erlanger 340B pricing. And this is for patients and providers who are eligible to use the 340B program. All right, so in summary, SGLT2 inhibitors have demonstrated benefit in type 2 diabetes with ASCVD and or CKD. They have benefit in CKD alone, heart failure with reduced ejection fraction, and now more recently, heart failure with preserved ejection fraction. The benefits and adverse effects of SGLT2 inhibitors are more of a class effect, so not necessarily specific to one drug. And the price of SGLT2 inhibitors remains to be one of the biggest barriers of utilization. Again, they are brand name only and can sometimes be difficult for patients to afford. Clinical considerations when recommending or verifying an order for an SGLT2 inhibitor. So what is the indication of this med? What is the patient's renal function? And is it appropriate? Again, just keeping in mind that there are renal parameters, but some more recent literature has gone outside of that. So if they fall outside of that renal parameter, it might not be an immediate no, but something to look more into. What's the patient's volume status? Because these meds do have diuretic effects. What's the patient's blood pressure? Because they can lower blood pressure. Does the patient have history of genital infections, bone fractures, or TKA that might lead you to making a different decision? And what is the cost of this medication to the patient? Will they have access to it? And will they be able to continue it? All right, this concludes my presentation. Does anyone have any questions? I had a feeling you'd ask me. Lauren asked how these medications contribute to euglycemic decay, and I do not want to recite the wrong mechanism of action to you, so or mechanism of this, so I am not quite sure. I know that's actually more common than you'd think, but I don't know exactly how that works. I will get back to you for sure. Yeah, I've had a couple people mention it's come up. Lacey, did you have a question? Yeah, based on the literature, I think the lowest they studied was 25 to 75. So just based on that, that is probably the lowest recommendation I would use to start an SGLT2 inhibitor. However, sorry, I'm trying to find it. Based on those KDIGO guidelines, if the patient was already on it and their eGFR fell below it, I'd feel comfortable continuing the medication as long as they're tolerating it well. Did you have a question, Emily? I thought I saw your hand up. Okay. Yeah. It was actually within like the weeks range. So they saw it pretty immediately. And as they looked in these trials for, a year or two, they saw that it definitely balanced back out as those receiving placebo kept declining because they didn't have the SGLT2 inhibitor on board. So I'd say the weeks to month range, it's pretty immediate. Any other questions? All right, let me pull up that CE credit slide. All right, and Lauren also sent out the instructions for receiving CE credit, but if you have any questions, I'd be happy to help too. Thank you.